welcome to our last capstone project of our presentation of this week. There's been some great ones this week, and so I'm looking forward to this particular one. I want to congratulate the students for making it through the semester and finishing through the project or through your program in a most difficult time. I mentioned earlier that the this past year, especially with epidemiology, how difficult it has been. And hats off to the faculty members, Doctors Drugi and Kennedy, and our whole host of adjuncts who have done a really good job at adapting in a very difficult situation. But you know, hats off to you as students for doing a great job. And we're thrilled that you're able to get this project done. And I also want to, you know, we've got to acknowledge Dr. Kennedy for her amount of work. It's to organize a capstone takes a huge amount of work, and not just this semester, but I know I've talked to her back in October how she was planning on this. So it does take a lot of effort on her part. So thank you, Maureen, for all your work. I do want to give Dean Ambler a quick minute or two to say, make a few comments, and then I'll introduce Dr. Kennedy. So Dean Ambler, thanks for being here again.
Hi, everybody, and thanks for having me. It's a real thrill. This entire week has been Capstone Week, and it's been Get Together Week. We know that things that are happening around the country mean that we have more reason to hope than ever before that this terrible pandemic is going to begin to recede. We hope so. In the meantime, here we all are, and it's just great to see you all. Great to see your faces, and great to anticipate your presentations. I've heard some really fantastic topics this week. Every capstone topic was carefully thought out and thoughtfully presented. And all of your classmates have done a really fine job working together. After all, a capstone means we have a large group of people all working on the same thing, but they come from different professional backgrounds and they have different perspectives. And that is exactly what public health is all about. What is public health about? It is seldom a single genius working all by themselves to solve a problem. Most of the time, it's a collective effort to solve problems. And if we can't get answers, we at least work about solutions or workarounds so that we can get through situations and do the best we can to assure the conditions in which people can be healthy. So it's a real thrill to be here tonight. Thanks so much for including me. And I know you're going to have some great presentations. We're going to be together again virtually at graduation, which is just a couple weeks away. Very exciting for those of you who graduate. Just by show of hands, how many people will be graduating this month? Okay, well, my message to you is have a great summer, but hurry back, because when you move ahead in your careers, we want to hear about it. We want to know about it. Come back to your old department chair, Dr. Kittleson, and come back to the dean's office and tell us what you've been doing, okay? Because we always want to stay connected, because we'll always be together. Thanks so much. Have a great evening. Bye.
Thank you, Dean Ambler. I have to compliment Dr. Kennedy and Dr. Drugi for how they have dealt with the COVID in teaching epidemiology, because it has been historically on campus, so they've had to do some quick shuffling. So I appreciate both of them. But for Dr. Kennedy, for this capstone, you know, she's a hard worker. You know, she's a hard worker, but she's also demanding, and you know, that's okay, because you want to become the best you are. And so all the sweat, tears, blood curdling screams that she's forced you to do, it's been for the best. And so I'm so thrilled to have Dr. Kennedy on this as a faculty member and as a colleague, because she's a good, solid worker. So Dr. Kennedy, this is your group, so we're looking forward to your presentation.
Thank you, Dean Ambler, and thank you, Dr. Kittleson. Thanks for everybody for coming. I know it's been an exciting week, but it's also been a very busy week, and we appreciate you being here. I have to give a big thanks to Michael Frankfurter, Michael Cotter, who without them, aside from Capstone, they kept us going for the past 14 months, and we'll be counting on them, in time to come. Last but not least at all, I want to congratulate the Capstone 2021 Epidemiology group for their hard work, their perseverance, their progress, and their success in their final research project here at the School of Health Sciences and Practice. However, I know it's not going to be their last. So I know everybody's ready. I know the group is ready, and let's get started.
Good evening, everyone. My name is Ash Jadhav. Thank you all for being here. Welcome to our Capstone project presentation on the topic Prevalence and Trends of Prediabetes Among United States Adults, an NHANES survey study 2007-2018. We have some very interesting information to share with all of you, so let's dive in. Next slide, please. Next slide, please. Me and my colleague Melissa will be introducing you to our topic today. Next slide, please. Prediabetes was first described in 1979 by the National Diabetes Data Group as a metabolic state between normal glucose homeostasis and diabetes. Previous slide, please. Prediabetes was first described in 1979 by the National Diabetes Data Group as a metabolic state between normal glucose homeostasis and diabetes. They called it glucose intolerance, and it was characterized by higher glucose levels, but not high enough to be diagnosed as diabetes. Next slide. Prediabetes was first described in 1997, where National Diabetes Data Group recognized impaired glucose tolerance and impaired fasting glucose as a new condition, and they named it prediabetes. 1 year later, in 1998, fasting plasma glucose threshold was reduced to 110 to 125 mg per dl. In 2003, American Diabetes Association further lowered this threshold to 100 to 125 mg per dl. World Health Organization did not agree with this criteria, mainly because the new criteria drastically increased the number of people with impaired fasting glucose, roughly from 6.7% to 24%. In 2010, ADA added glycated hemoglobin to the diagnostic criteria. Levels between 5.7 to 6.4% were diagnostic of prediabetes. Next slide, please. This is the diagnostic criteria recommended by the American Diabetes Association, and we follow this criteria in the United States today. Fasting plasma glucose level is measured post 8 hours of fasting, usually before breakfast, and levels between 100 to 125 mg per dl is diagnostic of prediabetes. HbA1c levels between 5.7 to 6.4% and glucose levels after oral glucose tolerance test between 140 to 199 mg per dl are diagnostic of prediabetes. Oral glucose tolerance test is done after 2 hours of drinking a sugary drink containing 75 grams of glucose. Next slide, please. The pathophysiology of prediabetes is a complex mechanism that involves multiple systems, and it is characterized by abnormal insulin sensitivity and abnormal insulin secretion, which is a function of beta cell, and this leads to beta cell dysfunction. Incretin deficiency and increased lipolysis can also lead to insulin resistance, which in turn can lead to prediabetes. Next slide, please. Prediabetes can revert back to normoglycemia with lifestyle interventions, but it can also progress to develop type 2 diabetes. Prediabetes creates a toxic environment in the body, which can give rise to micro and macrovascular complications. As seen by the statistics mentioned in the slide, there are increased odds of having these complications in a pre-diabetic adult when compared with a normal healthy individual. In general population, prediabetes is also associated with increased risk of all-cause mortality and cardiovascular mortality. Next slide, please. There are many risk factors, including modifiable and non-modifiable, which are associated with prediabetes. As you can see by the darker highlighted colors on the slide, of the non-modifiable factors, age over 45 years, gestational diabetes, and family history of diabetes have the highest magnitude of effect and have strongest association with prediabetes. Similarly, among modifiable factors, physical inactivity, obesity, smoking, and consuming alcohol have been shown to have the strongest association. Next slide, please.
Thank you, Ash. The complexities of prediabetes characterization results in varying prevalence estimates in the available literature. For example, prevalence reports vary due to diagnostic guidelines, the choice of diagnostic tests used, and the population being studied. A study comparing racial and ethnic variation in US prevalence estimates for prediabetes across 20 years found that non-Hispanic Blacks had lower IGT and IFG prevalence than non-Hispanic whites, Mexican Americans, and other Hispanics. Alternatively, non-Hispanic Blacks had a higher prevalence of prediabetes when using the HbA1c criterion. Next slide, please. The International Diabetes Federation reports that only 49 countries had high-quality data sources on impaired glucose tolerance. In 2019, the global unadjusted prevalence of impaired glucose tolerance among adults 20 to 79 years was estimated at 7.5%. This number is projected to increase to 8% in 2030 and further increase to 8.6% in 2045. Prediabetes prevalence is also highest in North American and Caribbean region at 12.3% and lowest in the European region at 4.4%. Globally, the prevalence of impaired glucose tolerance increases with age and peaks among 55 to 59-year-olds, then begins to decline as age increases further. This trend is also projected to remain consistent in 2030 and 2045. In the United States, an estimated 88 million adults, US adults 18 years or older had prediabetes based on fasting plasma glucose and HbA1c levels. Prediabetes was more prevalent among men than women at 37.4% and 29.2% respectively. Contrarily, age-standardized prediabetes rates were similar, prediabetes estimates were similar across all racial ethnic groups, education levels. However, non-Hispanic Blacks had a slightly higher prevalence, although this difference was not statistically significant. The prevalence of prediabetes was highest among adults 65 years or older, but there was no significant difference between those 45 to 64 and those 65 years or older. Since 2005, there has been no significant difference in the prevalence of prediabetes, but prediabetes awareness doubled from 6.3% to 15.3% in 2018. Next slide, please. Studies suggest that abnormal insulin sensitivity and insulin resistance began many years before the development of diabetes. As you can see on this slide here, the prediabetes stage already has decreased beta cell function. Consequently, 5 to 10% of all prediabetes patients will develop type 2 diabetes on an annual basis, and approximately 70% of all prediabetes cases are expected to develop diabetes within 10 years. The International Diabetes Federation postulates that if current trends continue, 700 million adults are expected to develop diabetes by 2045, with the largest changes occurring where economies are moving from low to middle income status. Next slide, please. Since prediabetes is largely asymptomatic, the economic productivity loss associated with early mortality and attributed sequelae is unlikely. Even so, the financial burden of prediabetes is significant. In 2017, the total economic burden of prediabetes was estimated at $43.4 billion, with an average cost per capita of approximately $500. Middle class per case increases with age, where those 65 years and older spend the most averaging around $820 annually. Compared to those with normoglycemia, prediabetes is associated with the greater use of healthcare services, medications, and other healthcare products. As you can see on this bar graph, the most utilized and expensive healthcare products among individuals with prediabetes were pharmaceutical prescription drugs and specialty care office visits. Next slide, please. Prediabetes is universally recognized as a high-risk state for developing type 2 diabetes, stroke, and other cardiovascular diseases. The aims of the study were to estimate the prevalence of prediabetes in US adults from 2007 to 2018, and to identify potential risk factors for prediabetes using data from a nationally representative sample. We also aim to provide recommendations and support for public health intervention, management, and policies. Next slide, please.
Thank you, Ash and Melissa. Good evening, everyone. My name is Leah Green, and my colleague Rosie and I will walk you through the methods. Next slide, please. So NHANES is a National Health and Nutrition Examination Survey, which is a program of studies through the National Center of Health Statistics that's a part of the CDC. It's designed to assess the health and nutritional status of adults and children in the United States. NHANES uses a complex multi-stage probability sampling design to select a sample representative of the civilian non-institutionalized resident population of the United States. Through this design, NHANES participant collection consists of 4 stages. Stage 1 is the selection of approximately 15 primary sampling units, which are US counties. Next, segments which are neighborhoods are selected within those counties. Then households are selected within those neighborhoods. And finally, individuals within each household are selected. Thousands of surveys are sent out each year upon stage 4 of participant selection. And those that respond accept a household interview. And out of those individuals, some agree to have a standardized health exam through unique mobile examination centers. NHANES releases data in 2-year cycles. And for our analysis, participants and variables were selected over 6 survey cycles from 2007 to 2018. Next slide, please. Almost 60,000 surveys were sent from 2007 to 2018. And from those, we included participants that were both interviewed and examined through mobile examination centers, were non-pregnant adults that are 20 years and older, had answered the question, "The doctor ever told you had diabetes?" and had a fasting plasma glucose measurement. Fasting plasma glucose was used as our indicator for prediabetes diagnosis, given that HbA1c wasn't approved as an acceptable lab measurement for prediabetes diagnosis until after 2010 by the American Diabetes Association. In the end, 14,812 participants were included in our analysis, and after selecting our target population, we selected variables. Next slide, please. Depicted in the table here are the variables chosen for a descriptive analysis, with prediabetes as the outcome variable, defined as a doctor never telling them they had diabetes and having a fasting plasma glucose measurement anywhere from 100 to 125 milligrams per deciliter. The descriptive analysis allowed us to examine the population distribution to determine if further categorization was needed, if the data was evenly distributed, and to reveal any outliers and missing data. We selected our variables based on previously published research and corresponding NHANES data, and each variable was categorized according to NHANES, the CDC, the ADA, or prior published research. Our descriptive analysis included a handful of variables, which included demographic and health and behavior, socioeconomic, biological and clinical, and psychosocial variables. For race and ethnicity in our demographic variables, NHANES had oversampled non-Hispanic Asians from 2011 to 2016, because prior to 2011, non-Hispanic Asians were not reported. Additionally, those that had identified as multiracial were collapsed to be among the other Hispanic category. The stratum for marital status was categorized according to having a partner, no longer having a partner, or never being married. Among our socioeconomic variables, we included SNAP Family PIR, which is the family poverty income ratio that is used to determine eligibility for the Supplemental Nutritional Assistance Program. A poverty income ratio of 1 means that a family's income is equal to the poverty threshold, and anything below that indicates that an individual is in poverty. Our greater than 3.5 poverty income ratio stratum represents individuals who are higher earners and likely have a higher socioeconomic status. For our biological and clinical variables, triglycerides, total cholesterol, and BMI were all categorized according to the CDC, while HbA1c was categorized according to the ADA. Next slide, please.
Thank you, Leah. So as stated before, one of our objectives was to develop a predictive model, which involves 3 main steps. Step 1 is a descriptive analysis, step 2 is the univariate analysis, and step 3 is the multivariate analysis. Leah just spoke to all the variables we did a descriptive analysis on, and after that, we performed a univariate analysis to test for association through a chi-square test, which allowed us to estimate the odds ratios. And we estimated odds ratios for many of the variables Leah mentioned, but what we have listed here are the statistically significant variables in the univariate at an alpha of 0.2. All of these variables also moved on to the multivariate analysis, and for our final model, we only kept those that have an X in the multivariate column. The purpose of the model is to predict the probability of being pre-diabetic as a function of potential risk covariates, meaning we can adjust for confounding. Another way to think about it is that the model allows us to isolate the relationship of an independent variable with the outcome variable from the effects of the other covariates in the model. And I'd like to bring your attention to 2 things in the multivariate. First, you'll notice SNAP family PIR was not statistically significant, but we decided to keep it in our final model to adjust for socioeconomic status. Second, you'll notice the top variable, survey cycle year, was included in the multivariate analysis and in the final model as a covariate. Survey cycle year is part of the weighted adjustment, and it's our main effect variable because we need to adjust for our cycles in a survey analysis. So basically, we adjusted for differences among our cycles. And after completing the model, we then performed a trend analysis to analyze a change in the estimated % prevalence of prediabetes at an alpha of 0.05. First, we did an unadjusted trend analysis within subpopulations according to the variables that have an X. After that, we performed an adjusted trend analysis, adjusting for survey cycle year and our main public health variables. Next slide, please. Leah had also previously mentioned that NHANES utilizes a complex multi-stage probability sampling design. And to adjust for the complex sampling design, we need to do a weighted analysis. And through a weighted analysis, we can generalize our results to the US population. Now, one thing to remember is that the data that we get from NHANES doesn't come weighted. We have to do something to it. And we do a weighted analysis through stratum, cluster, and weight statements. These statements have to be accompanied by specific variables. So we have two sample design variables to adjust for clustering and stratification. We also have a sample weight variable to adjust for unequal probability and selection, given that some groups are over or under sampled. So these variables were incorporated into our analysis to adjust for the NHANES sampling design. Next slide, please. All analyses were conducted in SAS version 9.4. To perform our analyses in SAS, we use specific SAS procedures. For descriptive analysis, which was step 1 of our model development, we used proc-freq and proc-means. The univariate is where the weighted analysis begins. This was where we started incorporating the stratum, cluster, and weight statements. Notice the code for SAS wasn't proc-means and proc-freq, it was proc-survey means, proc-survey reg, proc-survey freq, and proc-survey logistic, because remember, this study was a weighted survey analysis. For the multivariate, we used proc-survey logistic. In the unadjusted trend analysis, we used proc-survey means and proc-survey logistic. And for the adjusted trend analysis, we only used proc-survey logistic. And of course, all of these proc-survey procedures were accompanied by the stratum, cluster, and weight statements I mentioned before. Next slide, please.
Hi, my name is Alejandra. I know Purvi, Alisa, and I will walk you through our results. Next slide, please. As my colleagues Leah and Rosa mentioned before, to get to know our data, we run descriptive analysis of our variables. In the first table, you can see the most relevant sociodemographic, socioeconomic, behavioral, and clinical variables of our study and how they distribute among prediabetics and non-prediabetics. Of our 14,812 subjects, an estimate of 37% of our sample had prediabetes according to our diagnostic criteria. You can see that around 30 to 40% of people in each variable are prediabetic. For example, 43.1% of males versus 31.9% of females. Also note that the distribution between strata in some variables are very similar. For example, compare age 40 to 60 and more than 60. In both groups, 40% of the subjects have prediabetes. We can see that same distribution with BMI. There are not many differences between overweight and obese prediabetic subjects. Next slide, please. Other variables of interest are included in the table at the left side. Note the high number of missing values in smoking cigarettes. This is a characteristic that later limited our analysis. Now, if you look at our right side table, you will see our post-hoc analysis. These were subdescriptive analysis we run in variables like, have you ever been told you have prediabetes? Because we wanted to know more about the self-awareness of this condition. We found that of those people with high FPG, only 11% knew they had high glucose levels, and 89% of them did not. This means almost 9 out of 10 people did not know they have elevated blood sugar levels, suggesting prediabetes and potentially diabetes. When we look specifically at our subjects with high FPG, that's the table on the right and down, we see that approximately 90% of overweight or obese US adults have never been told of their elevated glucose status. Next slide, please.
Thank you, Alejandra. Let's discuss the results of our univariate and multivariate analyses. When you look at gender, the odds of being male among those with prediabetes is 78% greater than the odds among those without prediabetes after adjusting for other variables in the model. For age, there is not much difference between the two categories, and both the older age groups show statistical significance. Similarly, all the racial groups and marital status shows higher significance level. For SNAP family PIR, we can see the odds ratios are less than 1, which suggests that it might be a predictive factor against the outcome. However, only the lower socioeconomic status group shows statistical significance. Similarly, only the category of more than 5 times per week shows statistical significance. BMI showed the greatest association with the highest odds ratio compared to other variables in the model. For example, the odds of being obese among those with prediabetes were twice as likely the odds among those without prediabetes. The rest of the variables, moderate activity and total cholesterol, were also significant. When you look at the table, you can observe a lot of overlapping between the 95% confidence intervals, suggesting there's not much difference between the unadjusted and adjusted odds ratios. Next slide, please. So our results come down to this final predictive model with total participants as 14,429. So our final multivariate logistic regression model, or the logit model, is given as log odds of prediabetes is equal to beta constant plus beta coefficient of the final variables in our model. Next slide, please.
Thanks, Purvi. So next, we estimated the percent prevalence of prediabetes for each survey cycle with trend analyses. And what we found is that the overall unadjusted weighted prevalence from 2007 to 2018 was estimated at 39.4%, and this was statistically significant. Our trend analysis determined that there was, in fact, a statistically significant increase in the prevalence of prediabetes from 2007 to 2018. And as you can see here, prevalence sat around 40.7% in the first survey cycle and then increased to an estimated 48.5% by the last survey cycle. Next slide, please. We then calculated adjusted percent prevalence to see if there was any significant difference between the adjusted and unadjusted estimates. Prevalence was adjusted for the main demographic variables we assessed in our study, which were survey year, age, gender, race, ethnicity, BMI, and SNAP family PIR. And what we found was that there was no statistically significant difference between the unadjusted and adjusted weighted prevalence values. And in fact, the confidence intervals for all 6 survey cycles actually overlapped. But to note, the adjusted analysis also had a significant positive increase in trend. However, because the two models were so similar to one another, the unadjusted results will be presented and referred to for the remainder of this presentation. Next slide, please. We then assessed prevalence of prediabetes among each of the strata within our main demographic variables. So starting with gender, females were found to have a significantly lower prevalence of prediabetes as compared to males for all survey cycles, and both groups had significant positive trend tests. Moving on to age, the lowest prevalence of prediabetes was seen in the 20 to 39-year-old age group, and the highest prevalence was seen in the 60 years and older age group. All 3 subgroups we assessed had significant positive tests for trend, indicating that prevalence of prediabetes had increased over time. Next slide, please. So next, we assessed race and ethnicity. Of the 4 subgroups analyzed, non-Hispanic Blacks were the only group who did not have a significant increase in prediabetes over time, with prevalence remaining around 30% throughout all survey cycles. This group also had the lowest burden of prediabetes of all the racial ethnic groups we assessed. The groups with the highest percent prevalence were Mexican Americans and non-Hispanic whites. However, between these 2 groups, the 95% confidence intervals overlapped, so they weren't statistically significantly different from one another. A significant positive increase in trend was observed for Mexican Americans, other Hispanics, and non-Hispanic whites. Moving on to SNAP family PIR, the low socioeconomic status group had the lowest prevalence of prediabetes of all groups assessed and did not see a significant increase in prevalence over time. The highest burden of prediabetes was seen in the high socioeconomic status group. Both the middle and high SES groups had significant positive increases in trend. Next slide, please. And lastly, we assessed BMI categories. Prevalence was lowest in the normal or underweight group and highest in the obese group. The obese group was also the only group analyzed that did not have a significant increase in prevalence. Both the normal or underweight and overweight categories did have significant positive increases in trend, revealing that prediabetes prevalence had increased over time for these groups of participants. Next slide, please.
Thanks, Alyssa. Good evening. My name is Leslie DeRizio, and I'm joined with Nishat Anwar. Together, we will discuss our study findings. Next slide, please. To recap, this slide summarizes our study objectives. We'll focus on number 4 and 5 for the remainder of today's presentation and discuss health disparities with respect to demographic, behavioral, clinical characteristics, and make recommendations for public health intervention and prevention. Next slide, please. Based on our study results, we predict that 83 million US adults have prediabetes and that up to 74 million of them may be unaware. In our model, we identified gender, age, and BMI as potential risk factors for prediabetes, which not only increases the risk for diabetes and all-cause mortality, but has also been linked to the COVID-19 pandemic. Recent studies have shown a relationship between prediabetes and moderate or severe COVID-19 illness, in particular in those who were not previously diagnosed, reinforcing the importance of prediabetes screening as a priority. It also stands to reason that the forced home confinement, quarantine, or lockdown throughout the pandemic has likely increased negative health behaviors and increased risk factors for prediabetes. Next slide, please. Our key findings were a higher prevalence of prediabetes in males, older adults, and those with high BMI. Other risk factors in our model, and worth noting, include eating out more than 5 times a week, whether you live with a partner or were married, had high cholesterol, high blood pressure, and high triglycerides. Inconsistent and unexpected with previous findings, our study did not show an association with prediabetes among those reporting vigorous and moderate work physical activity. Next slide, please. Next slide, please. I think it's, there we go. Thank you. As previously noted, we saw an increased association with prediabetes in males versus females and believe modifiable risk factors like weight and blood pressure may have a stronger magnitude of effect in males. Other gender-specific differences for males that are related to prediabetes include low testosterone, erectile dysfunction, and a tendency in males to feature high fasting plasma glucose levels. So although gender is not a modifiable risk factor for prediabetes, developing our understanding of plausible biologic and lifestyle differences between males and females is worthy of further research, including analyses of risk factors by gender to inform prevention strategies. Next slide, please. Thank you. The Census Bureau predicts that seniors will outnumber children by 2035 and comprise 12% of the projected total world population by 2050. The CDC reports that the most prominent increase in risk for prediabetes begins in those 65 and older. Our study findings were consistent with these reports for age, as we saw statistical significance for prediabetes and those over 40 as compared to those 20 to 39 years old. Why is this? Older people are more prone to prediabetes due to deficiencies of insulin secretion and insulin resistance caused by changes in body composition and sarcopenia. However, other research has shown that almost half of older adults can also return to normal blood glucose levels following their prediabetes diagnosis. So although we do recommend that screening begin early, we also suggest that it not be based on age alone, but in combination with other risk factors for prediabetes, such as BMI. Next slide, please. Thank you. Physical inactivity and BMI are well-established modifiable risk factors for prediabetes and diabetes. Our results showed being overweight with a BMI over 25 is statistically significant risk factor for prediabetes. However, no association was seen between vigorous or moderate intensity of work activities. Conversely, we observed an increase in the prevalence of prediabetes among those who reported moderate activity in the prior 30 days. Although we cannot confirm a temporal relationship between physical exercise and prediabetes, our findings may be reflective of 2 potential study limitations, including the variable type and recall bias. Why is this? A recent NHANES study showed that almost 40% of participants met their physical activity goals during their leisure time, so not at work. So to explain the disparate results, additional analyses by physical activity subgroups may be warranted to provide a more comprehensive understanding of the true association between physical activity and prediabetes in future studies. To address potential recall bias, we also recommend that NHANES introduce validated digital technology and wearable devices to objectively quantify physical activity and improve our line of sight into the effects of physical exercise on prediabetes. Next slide, please. Earlier in today's presentation, Melissa highlighted inconsistencies in approaches for diagnosing prediabetes based on diagnostic criteria alone, as well as the variability in diagnosis often seen across tests between race and ethnicity. In our study results along the left, we observed that non-Hispanic whites and Mexican Americans had a higher prevalence of prediabetes, followed by other Hispanics and non-Hispanic Blacks when using fasting plasma glucose for diagnosis. These findings are inconsistent with CDC reports that race and ethnicity are major risk factors for prediabetes. However, consistent with our findings and along the right, the Centel study findings, which analyzed racial ethnic variations in US prediabetes prevalence based on diagnostic tests, also observed a significantly lower prevalence among non-Hispanic Blacks as compared to non-Hispanic whites when using fasting plasma glucose to diagnose prediabetes, which is consistent with the trends observed in our study. So now I'll hand it over to Nishat to walk us through the remainder of today's presentation. Thank you.
Thank you, Leslie. Primary prevention mainly focuses on education and awareness, increase physical activity, promote healthy diet, managing weight, and lifestyle modification. Secondary prevention is all about increased screening. As previously mentioned by Alejandra and Leslie, that there are a higher number of individuals who were identified having prediabetes, but they were never informed by their physician regarding having the condition, which highlights the importance of screening. For tertiary prevention, we have treatment options like metformin, which has shown to decrease BMI and risk of type 2 diabetes by 45%. Orlistat, which is an anti-obesity drug, can reduce body fat by 30%, regulate blood pressure, manage diabetic-related complications like retinopathy, nephropathy, neuropathy. Bariatric surgery is also an option for diabetic patients whose BMI is greater than 35 with uncontrolled comorbidities. Next slide, please. National Diabetic Prevention Program targets high-risk individuals through lifestyle changes and medication. PROP ABC study, which is a community-based intervention which offered intensive lifestyle intervention programs to offsprings of African Americans and European Americans with type 2 diabetes, and showed reversibility in the incidence of prediabetes among them. Diabetic Prevention Recognition Program, which works in collaboration with CDC in prompting guidelines for organization, regional training, and capacity building. It has been shown that intensive lifestyle intervention program can reduce the risk of progression by 58%. Next slide, please. Here are some of the strength and limitation of our study. As we are using enhanced data, we can generalize our study results throughout the US population. Using large sample size, give high power to our study. We are using multi-stage probability sampling. We're using weighted analysis. We can estimate prevalence and trend with high precision. No causality due to cross-sectional study design. There is a survey response bias due to decrease in enhanced survey response rate by 50% in the last two cycles, that is 2017 and 18. There's a potential of recall bias due to self-reporting for some of the variables like pre-diabetic awareness, number of meals prepared at home, and physical activity. Missing data was also observed for smoking status variable. Variables were changes over cycle for race, HbA1c, and moderate physical activity. There was a lack of family history data for prediabetes, which is one of the risk factors. There's a variation in diagnostic criteria was also observed. Next slide, please. Here are some of the key recommendations which we would like to put forward from our study are, there's a need to standardize diagnostic criteria to early diagnose pre-diabetic individuals, to improve awareness through education. At the local, state, and federal level, we can conduct health classes through dissemination of educational material or through social media. Screening should begin in early adulthood, not only for high-risk individuals, but for also those who are having higher BMI. There is a need to increase pre-diabetic research. NHANES can improve their survey response rate by adopting mixed mode survey methods, which include in-person interviewing, telephonic interviewing.
internet interviewing, and paper questionnaire. And a follow-up can be done from the participants via email or telephone, and some sort of incentive should also be kept for participants who are taking part in the surveys. There's a need to improve physician practice, and that can be done by conducting educational programs and seminars for primary healthcare provider for better understanding the diagnostic criteria and guidelines and how they can improve their communication with their patients, which can help them in better explaining the condition and what management and intervention of options are available for high-risk individual and for their patients. Next slide, please. Here are the list of our references from our presentation. Next slide, please. This brings us to the end of our capstone presentation. If you have any question, we would be happy to answer them all. Thank you so much.
This was fantastic. Really well done. You guys can be real proud of yourself. I'm blown away.
I failed.
Yeah. Hey, she smiled. This was really impressive. Let me just ask a quick question. You're in the elevator. You only have 15 seconds, you know, and you got a prominent physician in there. If you had to tell them one thing from this study that you only have 15 seconds, so it can't be extensive, what would that be?
My takeaway would be that specific and sustainable policies need to be implemented at the federal level to promote weight loss and behavioral and dietary and lifestyle modification programs. And that we need future research and exploration around prediabetes prevalence so we can tailor prevention and intervention strategies.
Okay, that's past 15 seconds. The elevator's already open. This person's leaving, but I like your idea. Who else? If you only had one thing to tell this person in charge of, let's say, internal medicine at a particular hospital or whatever, what would you tell them?
There's a need for increased screening, early screening, that you can identify high-risk individual at early stage, and that can halt the progression of the disease from pre-diabetic to diabetic. And that is a very good thing to decrease the burden all over of the disease.
Okay, good.
I can also say, it took almost 20 years to officially recognize this pre-diabetic category existed, that elevated but non-diabetic fasting glucose levels do exist. We need to act now and increase screening at physician care offices to enhance screening for pre-diabetes.
Okay, very good. All right. I'll let others ask questions. Nice job, folks. Really impressed. So I'm wondering, where are the guys? aren't there any male epidemiology students?
This is all women power group.
So I can ask a question. I thought it was a phenomenal project because it really, you know, you touched on so many things that I think are interesting and really timely, and especially looking at trends. Metformin, I know, has been, I saw something recently saying that metformin may actually not be recommended for pre-diabetes and things like that. So I think to gain information and see what kinds of things you're putting together, were there any variables that you wish you had had information on as you were going through all of this? Because, you know, once you have what you have, or variables that you might have wanted to see in a continuous form and instead they were in categories that you thought could have given more information another way?
So I can actually speak to that a little bit. There were quite a few variables that we all wanted to include when we were brainstorming, but couldn't because there weren't any corresponding NHANES data. Some of those would be like food insecurity, disability status, family history was a big one because Ash had previously mentioned that was one of the major risk factors, and unfortunately we couldn't find any corresponding NHANES data to include in our analysis for that.
Okay. Any variables that you wish you had continuous instead of categorical? You can say no.
So actually we did, a lot of our descriptive variables were analyzed as continuous, but we ended up categorizing them because given that continuous variables, they didn't have any measurable change over time. So for analytical purposes, we ended up categorizing them to measure the effect of each category on the outcome variable.
Yeah, and you did that according to guidelines, which was very nicely said, I think, by you, Leah. Nice job,
Okay.
guys.
Okay, nice job. It's true. Who is I agree. Dr. Kitson asked you using the 15 seconds to say one, important to the physician. I agree with you. They should do the more screen test, right? To find is those people is the sugar level is get into the diabetes impaired range. Okay, so if I'm the patient, I went to the doctor office, my brother's sugar level is now 109. That's actually, it's true. My brother level is 109. From your model, and tell me which variable will help me and will not go to the diabetes, or my sugar level can, getting a better from your model or from your study.
I can take this one. If I understand the question, you're asking if someone has elevated sugar levels, what can they do to reverse?
Yeah.
Okay, so intervention practices such as lifestyle modification and increasing your physical activity, changing your diet, eating more healthy foods have been shown to reduce the risk of type 2 diabetes and reverse the progression of prediabetes.
Yes, thank you. This which is what I'm doing. If I'm not doing, and in 5 years, I will be the added to another diabetes person. So yes, thank you. I'm doing the exercise at least 3 times each week. So thank you.
Also, I want to add to that, also limit smoking and alcohol, which can increase your chances of progressing to type 2 diabetes.
Yeah, thank you.
But it is interesting, the biostatistics study showed that low-level drinking can offset a cognitive decline. So yeah, you got to balance it out.
There are controversial findings. So there has been studies conducted which show like moderate alcohol consumption can be protective towards prediabetes, especially in Mexican women.
Yeah.
So yeah, there are controversial findings available.
So primary prevention is the main key for preventing the progression of pre-diabetic from diabetic. And it has been proven in different studies that people who are aware of their condition, if they don't adopt to primary prevention, their chances of developing pre-diabetic, as Dr. Shi mentioned, is within 5 years.
Yeah.
I have another question. Is there any information in the NHANES about different medications that the patients are on? There's a bunch of medications that increase blood sugar levels. The statins, supposedly, the corticosteroids, some of the antipsychotics. Do you have anything on that, or would you just extrapolate from chronic conditions that they may have been? Do they have any way of deciphering that or no?
So we did not include those who were on medications because of reverse causality, but we did have we did include data from NHANES who had like chronic symptoms like depression, and there have been studies which show that people who are depressed and who go on fluoxetine, which is an antidepressant, it is shown to improve their status, and they do not progress to diabetes, and they can prevent from getting diabetes. But yeah, we did not include those who were on such medications in our study.
Anybody on medications was out?
Yeah, because there was a lot of missing data for those variables, so we did not include those in our model.
Okay, great.
Other questions for these brilliant women?
Yes, I have some remarks. First, I want to congratulate everybody. Again, a lovely project, and I know this was a lot of work. Looking at medication data requires recoding data. So if it's a limited time project, this really is something, because I know I did it for my dissertation, it's a big job. So I can understand why maybe you didn't want to approach that. And missing data, of course, can be handled by imputation methods, which of course takes time. So I completely understand what you did and why you did it, but I think it's absolutely lovely. But my question is, do you think this pandemic is going to increase the prevalence in the next round of NHANES?
I can take that question. So at this point, there is limited data on the association between the prediabetes and COVID-19. However, data published in the primary care diabetes provides several reports that have consistently shown that pre-existing type 2 diabetes is associated with disease severity. So this would also include episodes of acute respiratory distress, intensive care admissions. So I do believe that it is possible that we will see an increase in association with prediabetes as a result of certain behaviors that have changed throughout the pandemic.
And also decreased screenings. People have not been visiting their doctors.
Correct. Yes, and that is something that we saw in the literature, and we were covering the COVID-19 as part of today's presentation, that it definitely, doctor's visits, screenings have been impacted. Very reasonable to assume the pandemic has intensified the prevalence of prediabetes in the United States. And also food insecurity is also playing a critical role together with physical activity. Yeah.
Great. Thanks again and congratulations. Good to see everybody.
Well, hey, folks, we've recorded this, so it's going to be posted. Give us sometime next week. Really impressive, but all in their own unique ways. So again, congratulations. This has been a horrific year in so many ways, but it's also been a phenomenal year, and you're part of that phenomena. And that when you're sitting on that rocking chair, looking past your life, you're talking to your grandchildren, you can say, you know what? I was part of the pandemic 2020, just like we all talk about the 1918 flu. It's just you've done a remarkable job through this past year, and you've made us proud to be new NYMC graduates. So continue doing good work.